Thank you very much. Thank you again, Professor Salah and all nephrology team in Alexandria for inviting me. Today I'm going to speak about the future challenges in hemodialysis, and I picked the black background, as you will see. It's not that black. Let me say that sustaining life with a machine was a dream that would have been achieved, and patients with chronic kidney disease are the only chronic patients who survive due to machine use, not like liver or heart or everything. It started in 1960, and up till now there is a lot of development. And also let me show you this very nice publication in August in Clinical Kidney Journal, showing two cases. One patient started dialysis as early as 1965 when she was 17 years old in Australia. She maintained life up till now. She is now 53 years on dialysis. And of course, she developed the chronic complication of dialysis over years. She has metabolic bone disease, osteomalacia, cervical neck stenosis, amyloid deposition, but she's still surviving because of her adherence to a special kind of food and exercise and living. And she said, I had 53 years of life living with an artificial kidney, and without it, it would not be here. I would not be here. In another case, a Croatian patient started dialysis as early as 1976, but he was shifted to home hemodialysis in 1983, and he is surviving up till now with no such complication, no bone complication, but of course his functional status has slowly declined. He is now 73 years old, and he suffered cardiovascular complication. And so it is not completely free of a bad outcome, even in the best scenario, that this is a fortunate patient, but most of our patients have increased all-cause mortality. And they have increased all-cause hospitalization, and hemodialysis is the worst among renal replacement therapy. And also the adjusted hospitalization and rehospitalization, which cost a lot of money, is higher 3 times than in non-CKD patient with a lot of admissions and readmissions. And this is reflected on the cost. Professor Hisham mentioned even giving albumin to the patient, and this will increase the cost of hemodialysis and survival of such patients. So we have a lot of challenges. The patient have challenges of survival, quality of life, hospitalization, nutrition, cardiovascular disease, anemia, frailty. While the nephrology community, we are fighting, I will not mention the cost, just of delivering adequacy, following guideline, following the recent advances. And also we are missing the bridge between hemodialysis, peritoneal, and transplantation. Most patients are offered one solution only, it is hemodialysis. And also in Egypt, we are missing home hemodialysis. We don't have home hemodialysis. And so we have a lot of challenges. And some of these challenges are seen. We can see it all together. The dialysis dose, the anemia, fluid, Professor Hissam mentioned it completely, anticoagulation, Professor Tariq, fatigue syndrome, Professor Mamdouh, and inflammation, solute removal, blood pressure control. We have a lot of seen challenges that need to be corrected or tackled to improve the outcome. Let me start by dialysis dose and the conflict between early versus late initiation. We know that giving more KTV have effect on survival and morbidity in this patient. And the use of the standard KTV is not available, but we can use now the surface area normalized standard KTV, which has a little bit better outcome in the dialysis dose delivered. It was measured in 2020. This is a very interesting publication by Dr. Das showing that this kind of KTV is associated with improved survival. So yes, we have to give higher KTV for our patient. And does the dose delivering increase survival? This is a nice review article in 2022 showing that by reviewing all the studies that have examined this item, and especially early versus late, including the ideal study, which has shifted us to do late hemodialysis, all this study again are non-conclusive or showing a little bit significant difference. And so the choice of whether to give higher dose or early versus late is based on a biased studies. And that's why the conclusion of this review article is that we are using randomized control trial in non-homogeneous patients, and we apply the conclusion for all our patients. And that's why they advise us to tailor hemodialysis regimen for each and for all patients. And this will increase the burden in nephrologists. And of course, we know that one size never fits all. So we have to individualize. And we have to remember that the older patient need less dialysis. The younger patient, female patient, and small size patient need higher KTV, not like we are doing in our dialysis centers. Professor Hisham mentioned volume because volume has a deleterious effect. Either hypovolemia or hypervolemia is associated with increased morbidities and mortalities. And so we need to adjust this volume status because our patients are fluctuating between acute hemodynamic stress during dialysis and chronic hemodynamic stress during the intradialytic period, which both reduce the survival and the quality of life of our patients. And we need to remember one very important subject just mentioned. Inflammation is related to volume overload. And we have to control the patient to the best volume status because this will induce inflammation. We have bioimpedance machine. It is expensive. We are not used to use it, but they may help in determining the proper volume of our patient. As seen in many studies, patient might be up to 7 kilograms more than his ideal body weight, and we don't know, and we cannot adjust his proper volume until he comes one day with acute pulmonary edema or acute decompensated heart failure. So volume overload is very important, and to maximize cardiovascular tolerance, fluid removal in volume expended hemodialysis patient should be gradual and distributed over significantly long time, not like what most centers do. They do 3 to 3.5 hour dialysis, but this publication in last year showing that we need to expand the time. Time is very important, and Dr. Das suggested that the volume first approach, where we base the dialysis time according to the volume overload of the patient. If he has more weight, he have more time and not less time. This is very important to take the 30 milli per hour per kg in our patient. Anemia, we all know how to manage anemia. We have to follow the guideline: hemoglobin 10 to 12, TSAT 30 to 40, and ferritin up to 500 or 800. However, there are also challenges. Medications are expensive, they are injectable, and we have now 2 new oral iron that can work in hemodialysis patients. The ferric citrate is not present yet in Egypt. It is a very good phosphate binder. Together with it supply a good iron and approved for treatment of anemia. And we have sacrosomial iron that is being studied in CKD and dialysis patients. Also, the injectable ethers can be now replaced by hypoxia-inducible factor, but we have to consider cost, of course, for our patient. This is ferric citrate showing very good effect as phosphate binder and as anemia treatment. And this is a new oral sacrosomial iron which has been evaluated for iron deficiency anemia in CKD patients with several successful outcomes. This is the outcome of using roxadustat. Yesterday, Professor Ahmed mentioned its effect. It is exactly like using EPO in such patients, but it is oral. One of the very important issues, Professor Hisham just mentioned, nutrition. Nutrition is very crucial, and Professor Iman Sarhan will give us in the next meeting a full review of nutrition. We know that the lower albumin is associated with mortality, and we know that the body mass index, the higher the better. We know that arm circumference, the higher the better for our patient. And we have to follow the curriculum or the nutritional guideline, which is changing, and it needs understanding. And in this core curriculum published in December 2021, he tells us it is not during dialysis that we should correct nutrition. We have to start early. in stage 1, stage 2, 3, and 4, because this nutrition will be changed. And we shouldn't prevent patient from eating proteins when he is CKD 3 and 4, because when he comes to stage 5, he will never eat protein again, and it will result in low albumin and bad dialysis outcome. So we need to individualize again nutrition starting from early CKD stages and not in the late stages where the patient will not eat well. One hinder of nutrition is potassium, but now we have peritomer. It's not present in Egypt, but we have Lokelma in Egypt, and it was proved by several studies it can maintain normal potassium up to 1 year in CKD as well as hemodialysis patient, but again, cost is a great challenge. CKD MBD, this is a big challenge with increasing patient survival. They develop, like the patient in the case 1, they develop severe bone changes. And this also not affecting just the bone, but the vascular and the cardiovascular metabolism and survival and cardiovascular complication. It's easy to say figures, calcium from 8.3 to 10, phosphorus, PTH, but it's proven that it is hard, very hard, to adjust phosphorus, calcium, phosphorus, PTH, and all together, even in the best center in the world. Why? Because even with the development of new vitamin D analogs, there is no effect on survival or mortality. And the only evidence in the guideline that support using non-calcium containing phosphate binder that has less calcification in cardiovascular system. And also, there is no major new development since sevelamer and calcimimetics. But finally, also we need to start early in CKD 1 and 2 and 3 and 4 before treating patients with advanced CKD MBD in stage 5. This is a great challenge. Among other challenges, but we have unseen challenge, just mentioned in the previous presentation. The major unseen challenge in our dialysis patient is inflammation. Our patients are inflamed, are in continuous inflammatory state. During hemodialysis, during peritoneal dialysis, they are inflamed. And inflammation comes from several factors, starting from nutrition to dialysate, to dialysis membrane, to hypoxia, volume overload, everything. And it will affect everything in the patient. Albumin concentration, C-reactive protein, weight, body mass index, body fat, sarcopenia, survival, it increased mortality, hospitalization, bad quality of life, and atherosclerosis. So we have to fight inflammation as much as we can. If we understand that all our patients by default are inflamed. And it also affects anemia, cardiovascular disease, and frailty. Frailty, Professor Mamdouh said, our patients have fatigue post-dialysis and before dialysis. And inflammation is a very great challenge. How can we solve inflammation? We have to remember that residual kidney function is a very important to keep in our patients who start dialysis. And usually this doesn't happen because of the excess ultrafiltration during the first few months post-dialysis. And keeping residual kidney function will prevent further inflammation and will increase patient survival. And this is a very nice illustration to how to lower inflammatory impact on dialysis, starting by quality of water, by using ultra-pure dialysate, acetate-free dialysis, biocompatible blood lines, biocompatible membranes, using high-flux dialyzer, absorbing membrane, sorbent cartridge, diffusion convention, and high-volume convention. And these strategies start with the water unit in our centers. We have to shift all patients who are using high-flux dialyzer and hemodiafiltration to ultra-pure, or even the best is the sterile non-biogenic substitutional fluid. And this is again a challenge in our centers. The selection of the membrane. Of course, if I mention low flux, Professor Hisham will stand now. We have to shift all patients to high flux membranes. High flux membranes that reduce the inflammatory impact on the patient. And this was explored by this very nice presentation, showing that using the higher flux membrane and even the high cutoff or medium cutoff membrane, the superflux membrane, is very beneficial in removal of inflammatory marker. And it has removed beta-2 microglobulin, amylase and albumin, and also the use of hemofiltration or hemodiafiltration will remove a lot of the middle molecule toxins that cause inflammation. And this is a nice publication from Mustafa Abdesalam. Most of us know him, and from Tariq Demirdash from Cairo University, and on patient on Saudi Arabia. They challenge the idea, what Dr. Hisham mentioning, is that high flux hemodiafiltration is better than high flux hemodialysis. They say no, they are the same, but when we dig deep, this is a few patients. And actually, in Ain Shams University, we have studied this issue properly using high flux dialyzer membrane, 2.6 meters square, in removing of a middle molecular toxins or maybe a high molecular weight toxin, the light chain and kappa and lambda. And it was published in Paris last May. And we showed that the using of this high flux, or it's not high flux, it is a high cutoff membrane or medium cutoff membrane, superflux membrane, have successfully removed kappa and lambda from our patient in hemodialysis and in hemodiafiltration. And of course, with hemodiafiltration, the removal was much better. And so it reflects removal of other toxins. It is not the kappa and lambda was the target, but other toxins also removed in this patient. And we will follow this study to show the effect on the survival and other inflammatory markers. And finally, treatment time, we have to know that less than 240 is a complete crime because the survival is related to 240 minutes per session, even in young, small, and even if there is no volume overload. And this was clear from the Japanese outcome studies versus European and American. But unfortunately, even in the United States, in the 2019, still only 1/3 of their patients are receiving 4 hours per session. And this is a great challenge to us and to everyone working in hemodialysis. And we have to use a multidimensional measure of dialysis. Let's start by the goals of NSH care. It is to maximize quality of life and to maximize survival. This is the ultimate goal. And to be achieved, there is potential dialytic strategies, which is treatment duration, treatment frequency, incremental dialysis properly, preservation of residual kidney function, and consideration of home dialysis, which should be present in Egypt. And the top of the pyramid for all our patients, what matters most is his quality of life. It is the life he is living. But let us remember that to achieve this pyramid, we have to start by the fundamentals. We have to correct the fundamentals. The hemoglobin, KTV, iron, urea reduction rate, the weight, the sodium, the cardiovascular, the albumin, the PTH, and everything. And it is using complex program to achieve that, which in the first stage to understand how we deliver dialysis to our patients, and we have to measure the effectiveness of our dialysis program by measuring by mortality, hospitalization, and also patient experience to achieve this top of the pyramid, which is the quality of life that our patients live. And thank you very much.